history taking and differentials. I put some stuff up on the board. Here you have the chief complaint. Chief complaint, you have to be able to understand the patients based on the complaint, their associated signs and symptoms. You get this by answering the questions and asking these questions, the history of present illness, OP-QRST, and sample history. And then you can run the body and then use a review of systems so that you don't get lost in trying to figure out what is going on with the patient. Again, it starts off with a chief complaint. I also identified some other things here. I put down the life spectrum. A complaint might be associated only with a particular age group, or it may not be, so you can rule out already based on a chief complaint. It also may be gender specific or gender bias, making it more likely to be a gender specific type of complaint. Again, to get better, when you decide, you need to look at addressing history so that you can elicit the associated symptoms. These are the pertinent positives, the symptoms that the person should have based on the emergency that they're experiencing the complaint on. They also present, when you show up, they present in a type of posture, behavior, mannerism, and they present with certain skin signs and findings when you walk into the patient's room. These should be addressed similar to the chief complaint. It should be associated with the chief complaint, all lined up with this story here. Now, more specifically, is you have to ask these questions to your patient, and it should be in a conversation style. So in the beginning, as you practice, I'd like you guys to stay focused by saying, hey, I'm gonna ask you this question, onset. So use the patient's name, get into the habit of conversing with them, say, hey, Joe, I need to ask you onset. Onset is when this pain started, Joe. For me, I need you to clarify for me, did it come on all of a sudden or suddenly, or did it come on gradually? Because certain complaints will tell you that if this emergency came on in an acute setting, all of a sudden, it changes our possible medical emergency. So onset is a great, it's a great determinant. Now, onset is a great thing. To me, the second best question as we prioritize our history would be the description. I need a description and a location. Because if the patient all of a sudden stops breathing, stops talking, is unable to elaborate any more information, what the patient is complaining about, the onset, the description, and the location can help me identify where in the body systems I need to focus on, and perhaps maybe even narrow that subject down, the emergency down to where I need to kind of focus into. So as we go down, we're gonna ask him, hey Joe, I need to ask you this quality, the quality of your pain, Joe. But basically it's, Joe, I need you to describe what you're feeling there, Joe. Because it may not be pain for them. In some cases, there may not be pain at all. It may be a vague discomfort, it may be an uncomfortable feeling, but definitely not associated to a pain. But if we give them only a pain response, then the patient is just gonna say either positive or negative to the answer that we asked for in that question. So, Joe, do you have pain? His only answer could be yes, or the opposite would be no. And in some cases, patients say, I'm not having pain, so where does it get you, right? So we ask, what do you describe this feeling then? And then, Joe, I need to also find out the location. So the location would be in the radiation and provocation, but it's like, where is it, Joe, and does it travel anywhere? So Joe, I need to know, where is this pain? Can you pinpoint it to me? Can you generalize it? Tell me where it is. Now the rest of the questions are important, but it's the clarifying questions that once they tell you, I've had this pain before, or I've had this pain and it was treated before, or take this medication and it makes it better. Anytime you can kind of clarify and build more upon it, it may help to unmask the clinical emergency that you're responding to. Now let's take a look at the focus exam or focus physical exam here as PE. We're looking for the associated signs and symptoms, the ones that make this, or the ones that are absent in this emergency that we're possibly trying to narrow and focus down. So we would do our cardiac, respiratory, abdominal, GU, or neurological exam. We would do all of these while we're trying to identify and review the chief complaint and the history that we're going on. This might also mean when we're doing these focus exams that we are also using other diagnostic tools such as a glucometer, a tympanic temperature, an end-tidal CO2, a SpO2. These are just added information that will build the case to sort of narrow down our differential. And then lastly is to rule the body and just kind of make sure we don't forget anything by doing a pretty good head to toe and using the head to toe as an outline to ask questions. In the medical field, we tend to have our own little T-sheet or some type of ROS sheet where we have patients either fill this out prior to their visit or where we're going to do it during our examination. But it basically focuses on everything as we move down the body. We ask questions relevant and pertinent to the area that we're examining. So for you folks, we can slowly start to build this up, but this would help us to capture anything that we may have lost in the initial assessment and exam that we're doing. Again, this is only going to be helpful if you know a quite large differential diagnosis for these complaints. So let me add a few other things here. I put it in green, so time. Certain times of the evening or day, you may be called for, or week, you may be called for a certain type of patient. You know, if it's 2 a.m. in the morning and there's a major complaint such as chest pain or shortness of breath, it's very unlikely that it's going to be some type of benign, not, simple call. Especially if you identify then the location of where this call is being generated. On the other hand, it also could mean that this might be some kind of simple call that maybe would require other providers or other 911 assistance and other elements to respond to the scene. For example, if you're called to a hotel at 2 a.m. in the morning and the medical facility or the security is calling to wave you in there and they're telling you that the person's having trouble breathing and they're worried, it's probably going to be a very, very critical call or a legitimate call. On the other hand, if you get called to a bar at 2 a.m. in the morning, it still could be critical, but you can kind of understand that the timing and location, the time of it and the location can also help you kind of narrow your differential diagnosis down and where to go with this. Again, you need to have a very broad differential diagnosis when we do a complaint. And just for example, we'll go start off here. Let's just use something as weakness. So you have a patient that complains of weakness, and as we start talking to them, they also say they complain of nausea. And anorexia means that they're not eating that well and they're not having appetite. We have 3 different complaints here, which they could all be relevantly related to one another, or it could be just coincidental and they're not related at all. And so we'll have to tease out each different complaint. That means that we'll have a special set of questions and history to find out what's causing these symptoms. Again, these are just symptoms and they're not necessarily a differential or medical emergency per se that we're trying to piece together. You can think that this may be something like an MI or cardiac type of chest pain, cardiac pain. This could be a stroke, a neurological event. This could be a GI bleed. This could be anything here. You're not going to have to look at the way the patient presents with signs and symptoms. You're going to need to then address their complaint based on your sample history and OP-QRST, and then clarifying questions. This is really broad. So now I want you to practice asking these questions to each other and using it in a conversation piece. Again, when we focus on the history, we're going to also use that by asking the patient to allow us to do an exam. So everything that we're doing, we need to explain to them the process, procedure, or the technique that we're employing, the examination that we're doing. If you find some flags, these are things that you should want to, like, you know, throw out there and tell everyone this is what we found. And this is some things that we should expect. So in the pertinent positive and pertinent negatives, both in the history and in our assessment, as we go down our medical emergency differential, if I thought this person right here in the background here is having a GI bleed, then I would assume that this person should have some kind of black tarry stool. He should have some type of coffee ground emesis. I would look for the conjunctiva and skin color to be pale in color. The pulses may be weaker peripherally, stronger centrally. Maybe some orthostatics that are going on. History of some kind of NSAID or aspirin use. Peptic ulcer disease. Maybe on some H2 blockers, protein pump inhibitors, and had a previous diagnosis of maybe some of these things. On the other hand, if it was something like a neurological event, then I would try to find out if there's any type of memory loss or any type of one-sided hemi weakness. Like the weakness, is it just one side or is it the entire body that's being weak? And as you do this, then I'm going to throw laps out at them. And I'm going to find to see if there's any type of weakness where they kind of drift or they kind of have an issue with posture and not sitting upright, slurred type speech, visual changes and the like. And if this is more cardiac, doesn't mean that we always throw the cardiac monitor on every patient, but if this seems to be more cardiac, it came on when they're exerting themselves, it seemed to go away. There was a process over the week or so that they've had several spells of this type of weakness. Shortness, weakness, nausea, and anorexia. And then we end up eliciting that they might have some shortness of breath along with the event, and it tends to go away. This might be somebody that's having an MI or angina, and this could be a diabetic patient that has a higher risk factor to have this. But it all depends on how I organize my history and my thought process. I hope this helps.